the victory alone is not the change we seek. It's only the chance to make that change. And that cannot happen if we go back to the way things were. It cannot happen without you. Does anybody know who said that where and when? Barack Obama, election night, Chicago. And I think that has particular relevance to the topic we have tonight, which is what are the opportunities and challenges of federal healthcare reform really operating here at the local level in Santa Cruz County. And here to help us think about how we can all be part of that change are two real brainiacs on that subject. And we have Assemblymember Bill Monning. You know him as our native son. He's the chair of the Assembly Health Committee, deeply committed to the health and well-being of our communities. Welcome, Bill. And Peter Long, a guy who was blowing my mind even during the hors d'oeuvres section tonight, CEO of Blue Shield Foundation, and I think one of the smartest guys on the planet, I'll have to begrudgingly admit. What are we talking about with federal healthcare reform? Well, very broadly, three topics. There's coverage expansion. We know that 2014 is going to bring coverage opportunities to about another 6 million Californians. Here in Santa Cruz County, about 20,000. We're also talking about insurance reform, making what I would have to call our uniquely American system work better. You know, we have the individual mandate kind of shaking hands with guaranteed issue. It means that not only do you have to be covered, but you'll be able to be covered. And then finally, we need to be thinking about bending that cost curve so that the healthcare costs don't crush all of our other social agendas. So we'll be talking a little bit tonight about accountable care organizations and how the nation, as well as Santa Cruz, is moving in the direction of talking about value in healthcare. So there's lots of opportunities, but no kidding, there's lots of challenges too. And so as our speakers make some introductory comments, be thinking about what questions you want to ask them tonight. And I'll be leading off after their comments with some teaser questions to get us started. Sit back, enjoy the evening, and let's work on this together. So I'm going to ask Assemblymember Monning to introduce this topic.
I think in these opening comments to try to give kind of the broad overview, much of this that you'll be familiar with as we get into the Q&A, maybe drilling down into some of the many moving parts. But the Affordable Care Act, passed by a majority of both houses of Congress, signed into law by President Obama, immediately achieved certain reforms that had been elusive for decades. The moment that law was signed, health insurance companies could not deny coverage for a child between the age of 1 and 18 who had a pre-existing condition. For those families, that reform is real and it was immediate. It also offered coverage to young adults up to age 26. The key there being a parent had to have a plan, there'd be a cost, but again, they could not deny eligibility. As we approach 2014 and the implementation date for the exchanges and many other elements, that prohibition on denial for a pre-existing condition will extend to everybody who is eligible, and I'll talk about a couple of exceptions, but no denial of coverage for a pre-existing condition, and no cap on coverage in terms of cost. Somebody afflicted with a grave disease or illness or injury, that insurance plan cannot say, okay, you've reached the maximum payout, now you're on your own. So these are fundamental reforms in an imperfect system that we live in now, and as we move forward, I think they should be seen as important incremental reforms, and yet with some remaining challenges in terms of truly achieving universal, comprehensive health care coverage for all Americans. So a significant gap, in my view, of the Affordable Care Act and the politics of Washington, D.C., it specifically exempts undocumented workers from eligibility. Well, from a public health point of view, germs do not discriminate based on whether somebody has a green card or legal papers. And so if you're trying to build structures of public health and promoting vaccines, prevention, good health practices, early detection, when you exempt a sector of the population, and it's a huge sector of our Central Coast region, that to me creates a hole and a default in the effectiveness of that system. Now, will that undocumented workforce not seek medical attention? Well, often they don't for fear of deportation, but now the door that will be open will continue to be emergency rooms as opposed to primary care, medical homes, and all of the architecture of the Affordable Care Act that seeks to reduce costs by putting in investing more in prevention and wellness and medical homes where people can receive the preventive care and diagnosis and screening that can prevent more catastrophic, higher cost entries into hospitals. So I know Santa Cruz County's been particularly dynamic and innovative with children of undocumented workers having a philosophy of coverage independent of legal status. But this will continue to be one of the political issues. And I think the role that I'm in the state legislature, it's a political position. Healthcare and healthcare experts, all of you in this room, you approach the challenge of healthcare and healthcare delivery as practitioners, as public health officers, as implementers, and healers. When you cross that divide into the political arena, we face challenges where decisions get made not necessarily on the best outcome for patient, the best outcome for community health and medicine, but often what's possible in a current political climate. So the reform that was achieved in Washington, D.C. was the best that could be achieved in that political climate. And yet it's still under attack. And a number of states have filed lawsuits in the federal courts challenging particularly the mandate of the Affordable Care Act. Other courts have upheld the mandate. Some courts have ruled that it does go too far. So this is headed to the U.S. Supreme Court, where we anticipate a split between 4-4 and probably Justice Kennedy casting that decisive vote. So what happens when we've gone to all this effort? In California, one of the first to establish the medical exchange, Governor Schwarzenegger, to his credit, I would say, and I don't say that very often on very many issues, but on healthcare reform, he never hesitated in directing his departments to move forward towards implementation. When some of his counterparts in other states were resisting, continue to resist, continue to rely on the courts to block implementation. So California, we've had a head start. We have established the exchange, and now our challenge is the establishment of the exchange creates the mechanism to provide coverage to people currently uninsured, anticipated in California between 2 and 4 million, depending on category of eligibility. About 8 million Californians currently without insurance. And if you do the math, that gap would be undocumented workforce. Counted in the census, but not eligible, at least for immediate access to the exchange. So as the exchange is put in place, the role of the exchange is to offer like products from private sector health insurance companies, and similar to what was done in Massachusetts, creating levels of coverage that vary based on premium costs, vary based on deductible, and get ranked as bronze, silver, gold, platinum. And the key features that anyone putting their product up there, it has to be similar coverage at the different levels. And then there'll be certain things we call essential benefits, that anybody who wants the right and the privilege to sell their healthcare coverage product on the exchange, certain essential benefits will have to be covered. maternity coverage. A lot of this is still in the pipeline at the federal level, and one of the tensions between California, the health insurance industry writ large, and the federal government is we've sought in California in some instances to move ahead of the federal government in defining what we think should be essential benefits. Mental health care, and some other, the coverage of families with autism as a medical condition, not as an educational disability. So these were hard fought, they've been controversial, and they are now the law of the state of California. And our hope with some of those where we were more proactive, when we said, why don't you just wait and see what the federal government does? We're hopeful in California that some of that work will actually inform the federal government as it unfolds and decides on what essential benefits will be. One bill that I had this year that the governor signed, AB 922, takes an existing office of patient advocate and empowers it to become the hub for, we use the parlance of consumers, and that's the business model. It's the Office of Patient Advocacy, and the role of what AB 922 will implement is a one-stop hub for people who are seeking information as to what they are eligible for, or once the plans start rolling out, if they have a complaint. Under federal law, the exchange has to have a mechanism to capture complaints and be able to report how the complaint was resolved. So AB 922 will establish that hub. It will continue to access. We have so much oversight in this state and nationally, depending on what the healthcare product is, from the Department of Insurance to Department of Managed Healthcare Services, and currently all of them have 1-800 numbers, but you need a lawyer and a health professional to even get you to the right number to phone. This would seek to concentrate that service. It would be linguistically and culturally adapted, and it would also contemplate working with local organizations, FQHC clinics, legal aid offices, who could help interface with patients who will never pick up a phone themselves and call a 1-800 number. So it contemplates that there are certain members of our community who won't have the capacity or the courage or the sense to go to the 1-800 number. So we will have community hubs that will also help people navigate that. So that will be moving forward with its implementation. But then people say, well, should we really push this forward at the rate that we're going when we still don't know if the federal court, if the U.S. Supreme Court is going to uphold the mandate? Because the U.S. Supreme Court could invalidate the mandate, uphold other components of the Affordable Care Act, but critical to its financing is the mandate. You expand the risk pool, but you have, in addition to increased Medicaid, Medi-Cal support, expanded eligibility, particularly for poor, and raising that level of poverty for eligibility to go on the exchange. Key to that capacity is also having people that will buy their own coverage on the exchange. And so if you eliminate the mandate, the architecture of the Affordable Care Act is in jeopardy. Now, from my point of view, and some people may differ with me in this room, I've been a strong supporter and proponent of single-payer health care. In my view, if the mandate is ruled illegal, we should go back to the conversation in California of how at a single-payer system, with the features of the Affordable Care Act that's still intact, be best implemented and financed in the state of California. Now I'm curious to Peter's response to that, because I think he may have a different view. The one model we're looking at right now is Vermont, which has exercised its right under the Affordable Care Act. It's called exercising a waiver. They are pursuing implementation of a single payer system in Vermont. But it's a very different state than California. So we just have to pay attention. For those who say we really should slow down in California because we don't know what's going to happen in the court, regardless of what happens in the court, we need to move California's healthcare, health delivery, and prevention programs into the 21st century. And we need to do that with intention and purpose. And as Ellie said, all politics is local and all healthcare is local. A lot of what's happening in our communities right now is indeed pioneering. I have the ability of looking at what's going on in Santa Cruz compared to Monterey County, compared to Santa Clara County and other parts of the state. And I think sometimes you're not aware of how pioneering Santa Cruz County has been, not just in the delivery of healthcare, but right now in the promotion of health and wellness. And to me, the fundamental problem of healthcare delivery in the United States is that it's a business, and the business interest sometimes goes counter to best health interest and health promotion. Some of the work I see going on in Santa Cruz County, the healthy lunch programs in our schools, the farm to school, the second harvest, even the food banks who used to scramble for any contribution of food they could get and were very non-discriminating, now don't package unhealthful foods. And so we have these trends and these models of getting in front of that curve of trends of child obesity leading to preventable diabetes, heart disease, etc. Do you know 30% of Latino children in the state of California will have preventable diabetes by the age of 30, 50% by the age of 50. And to me, as an optimist, I think you have to be to do the work that we do in Sacramento. The key in that statistic is preventable diabetes. And that's where communities can pull together. We can educate, we can activate, we can motivate, and we can measure the change in people's health and their lives. So I think I've perhaps rambled a little bit too long. I'm going to stop there, and I'm looking forward to questions and our interaction. And again, thank you all for this opportunity to join you this evening. Thank you.
So I just want to start thanking Ellie for inviting me and Rama, and just share with you that they came. I invited them to come and speak to our board at the foundation a month and a half or so ago. And to understand the story, I'm relatively new at the foundation, been there about a year and a half. And I presented, about a year and a half, my first month in, I presented this bold plan. We were going to help locations in counties like Santa Cruz, but every county in the state to take full advantage of health reform. It was an ambitious plan that said local determination, all healthcare is local. We're going to put our foundation resource, we're going to fund counties. Counterintuitive, a private foundation funding counties to do their work. We're going to go all in on community health centers. It was incredibly ambitious plan. My board looked at me and said, slow down. Young guy, just slow down, get your feet wet. You've been here a month, just take it easy. Well, a year later, Rama and Ellie come, and I think this is causal. So Rama and Ellie came and presented what's happening here in Santa Cruz. I went back after the amazing things that you're doing through HIP, whether the patient-centered medical home work, the outreach and enrollment work that you're doing, just all of the things that are happening around your low-income health program, the integration of services, going at full risk for high, dually diagnosed folks with behavioral health and medical conditions. They presented for about 25 minutes to the board. After they left, my board said, how fast can we do it? Let's get on this immediately. And I spend, as Bill does, I spend a lot of time going around the state and talking to different folks and working with different counties. It is remarkable, A, what you're trying to achieve here. I mean, I think and you're ambitious, it's audacious goal and incredibly ambitious, but how far you have come in a relatively short period of time with your low-income health program and with the patient-centered medical home and your collaborative projects. The MetaCruz work is fantastic, and you all should be applauded for how well you are doing. I think Bill gave an excellent summation of where we are on national health reform and some of the implications. I just want to leave you with three thoughts, or just kick off three thoughts for you about what it means for Santa Cruz. And the first thing I say in every speech I give now is health reform is not self-implementing. It is not self-implementing and is not deterministic. And for a lot of reasons. Some that Bill mentioned about people who don't like health reform want to see it go away yesterday. The law can only say so much. I know people love to, in the media, talk about this 2,200-page bill or the 900-page bill or the 1,000-page law. The reality is that is only a framework, and it can only be a framework. There's nothing that can be said in a federal piece of legislation that can tell you exactly how things are going to work here in Santa Cruz or anywhere, even in California. They can provide guidance, they can set the framework for it, and they can do certain things that Bill talked about, which are linear and deterministic. Some of the insurance practices, those are done. The other point that it's not self-implementing and it's not deterministic is when we talk about these estimates, let's be very clear that they're estimates. None of us should sit back and say, let's look at the calendar, 2014's coming, we're automatically going to get these 4 or 5 million people covered. Those, as I call them, are good case estimates. They're not the best case estimates, but they certainly are not going to happen on their own. They're not going to happen if we don't set up the exchange thoughtfully. They're not going to happen if we don't create a culture of coverage here in California and across the country. They're not going to happen if our eligibility enrollment systems don't work. All of the things that we're thinking about these coverage expansions, it is an opportunity for us. It is not predetermined that we're going to be successful. Okay, I think we really need to know that, and we all have to be part of the solution. None of us can sit back and say, I'm lukewarm on this, on the law, I'd rather have a different solution, or I'd rather have this, or the feds have taken care of it, or I'm going to wait to see what the Supreme Court said. So we all need to be part of the solution. And a lot of the things that are going to determine how many people enroll in health insurance and how wide the coverage expansions are happen here. They don't happen necessarily. They're not a piece of legislation. It's not a regulation. It's not even how the exchange is set up. It's actually how it plays out in communities, how health providers promote it, how the promotores and navigators work, what your systems of care are here. So I think that's incredibly important. I think that's the most important thing I leave you with. The second thing I would say is Medicaid. And it's interesting, you don't hear a lot of folks talk about Medicaid nationally, or even in Sacramento. Medicaid and Medi-Cal here in California is an essential building block for health reform to work. Okay, it's incredibly important because 2 million of the 4 or 5 million people that we're going to get covered are coming into Medi-Cal. Why is that important? I think to me that's the good news, bad news scenario. I'll start with the bad news because I would like Bill an optimist. The bad news is we've got real access issues in Medi-Cal today. And you just saw that the CMS, the federal government, the Obama administration just approved further rate cuts for primary care, 10% rate cuts for providers. That will have real and profound implications on access to care. So there is a real question, and again, it's a real question of whether coverage will lead to better access to health care. The point of the Affordable Care Act is not just to provide health insurance. And yes, I work for a health insurer, and health insurance is good, but it's to actually make sure that people have better access to high quality health care that they can afford. And so we need to make sure that the second part of that equation is true. And obviously we have federally qualified health centers who provide those services for both people in Medi-Cal and the uninsured. But I think we cannot underestimate the challenges and the irresistible force of health reform meeting the immovable object of our state budget. And I think, again, that's a very, very important issue. The good news on Medi-Cal and why Medi-Cal is such an important part of health reform is that we have this thing called the 1115 waiver, which is a research and demonstration project that can bring up to $8 billion to the state of California using county money to draw down federal funds to start health reform today. In Santa Cruz, I think I've got good news tonight that your application for your low-income health program is being sent to the federal government tomorrow for approval. So congratulations on that. So on one hand, we have this incredible economic challenges or budgetary challenges with Medi-Cal, but we also have this tremendous opportunity to redesign the health systems for low-income people in Santa Cruz and low-income folks across the state. That is real. There's real money involved in it, and it actually is leading to system change. The challenge will be that those are programs between now and 2014, so about 26 months of an incredible program. People are doing amazing work here, they're doing great work in LA, they're doing great work in Alameda County. It's what do we do with those systems of care that we build when people move over into the Medi-Cal program? Do we use them for the undocs? Do we use them for the remaining uninsured? Or do we go back and say, oh, that was fun, now let's go back to business as usual and our Section 17,000 responsibility? So one of the big questions for county, Santa Cruz and others is, you are doing tremendous work to integrate your healthcare system now. You're thinking about even integrated financing. So you actually are way ahead of the curve on value. And this program that you're about to start is actually going to drive the value discussion about we are paying for health outcomes, we are providing the highest quality of care to our most vulnerable citizens, and we will derive the benefits from that. So I think you guys are ahead of the curve. The question is, can everyone else in the state catch up to you? Will state health policy support you to continue that work going forward? And will you, elected officials here and others, kind of take that with you? My third message, I think it builds on Bill's point about his piece of legislation, which I think is, if I said there are lots of great things happening in Sacramento, I think the most promising from my perspective was 922. And that's my premise that, like we have way too much conversation about medical care and not enough about public health and population health and prevention, in health reform, and any doctors don't take this as criticism, I'm married to one, so we have a lot of supply side conversation about how we are going to build this field of dreams, whatever it may be, and people are going to come. So if we build it, they will come. I think we need tremendous amount more conversation, analysis, dialogue with patients, with people, with community. What are their expectations for the healthcare system? What's their role in their own health? How do they want to be involved? Because my concern is that we can do all of our supply side planning, we can devise excellent legislation, regulation, frameworks, bodies, all of these things and systems of care, but if we haven't gone out and really had an honest dialogue with people's expectations, their desires, their aspirations, their fears, we're going to have a system that people may not actually show up or it may not achieve its full potential. So I think one of the great things about HIP and about Santa Cruz is that people here tonight, not everyone here is a provider, and that you're actually taking this conversation beyond just the technical delivery system financing conversation to what are people's expectations? How do you want to be involved? What are your aspirations? So I think the three things, if you put together, we're part of the solution, to build on the successes that you're having in Medicaid and make sure we don't forget the patients in all of this, I think I am optimistic about health reform and that it can achieve its full potential to improve our health outcomes and improve the health of the whole community. So thanks, I look forward to the questions.
Challenges on the legal side, individual mandate. I think we know that incumbent presidents have a hard time overcoming the kind of economic indicators we're looking at these days. When you kind of put it all into focus, is federal health care reform actually going to happen?
The answer is it is happening. And I think that is the most important. I saw this question in advance, I have to confess. And so I diligently read Nate Silver. I said, all right, Nate, tell me who's going to win the election. If anyone knows 538, Nate is the biggest data cruncher in the universe. He's a brainiac. And he had 50 different scenarios. And at the end of it, I said, I don't know. But I think the real answer is, despite the politics and the constitutional challenges, there is so much momentum and energy, whether it's from health insurers like Blue Shield and others, and Anthem and Kaiser here in California and nationally, from employers and payers who've begun to change their systems, who've already made the enhancements for coverage to 26-year-olds, no longer denying for pre-existing conditions. I mean, people have already invested billions of dollars to get ready for health reform. So I would say even if we had a change in administration, it would be very difficult to roll back all of health reform and to say, let's do a do-over and start again. That being said, I think there are a lot of scenarios where there's a death by 1,000 pinpricks, which will make the work that you all are doing in Santa Cruz even more important, that you're demonstrating value, you're using systems that, kind of building systems that are palatable to the community and that work and that have traction, because I think those are the systems that will be enduring, and those are the changes that actually, no matter what the kind of policy environment is and how toxic it becomes, will survive any of the legal challenges. I mean, I think value-based healthcare is here to stay, and I think the framework for health reform is here. The question will be, and you can see it already, where funding is, things are defunded if they weren't funded for 5 years and the funding wasn't guaranteed for 10 years. But so the answer is health reform is here. It may look very different in 2014 and 2016, but I don't think we'll go back to a pre-ACA days.
I think that was pretty comprehensive. I would just key off of that question and something that Peter raised, the importance of Medicaid, Medi-Cal funding to the ability to implement existing health care coverage under Affordable Care Act, and that necessarily crosses into the political arena of on the one hand, California is committing to move forward with the ACA, but because of our own budget crisis, we're taking money off the table that would have pulled federal dollars into California right now, reducing reimbursement to providers of Medi-Cal, limiting patient access, all because of budget constraints. So without getting off track into a broad budget discussion, let me just summarize. California's revenues have dropped 30% since 2008, direct result of a national economic recession. Americans lost $5 to $6 trillion in retirement, investments, etc. And yet we're focusing on public workers' pension plans as the culprit, as opposed to who got us into this mess. And again, at the risk of sounding too political, to support healthcare and the vision we have of healthcare, we need to get off the ropes of being on the defensive and fighting to limit the gravity of cuts and be able to articulate a vision for healthy communities, a robust and healthy healthcare delivery system, and have the conversation, what is a reasonable amount of money to mobilize to support those objectives, both at the federal level and the state level, and then have a conversation, what is an equitable way to raise that. And I would just close that maybe the Occupy Wall Street 1%, 99%, there should be a piece in that conversation that focused specifically on funding for health care in the United States.
I think we will see coverage expansions, and I think those will be profound. And one of the things, we did a survey at the foundation of 1,000 Californians who earn less than 200% of poverty a year, so about 40,000 for a family of four, and asked them what their expectations were for health reform. Not, enough about me, what do you think about me, or what do you think about the law, or, do you not like, but more fundamental, what do you think about, what are you expecting for primary health care? And the responses were powerful, and 44% of the folks said they don't think they have a choice in healthcare today, but 60% thought they were going to have a choice under health reform. When health reform is fully implemented, they think they'll have a choice in healthcare providers, and they're looking forward to exercising that choice. So I think that is a really fundamental thing that will change, that people will not be forced to go only to where they can afford to go, that they'll actually have power over their healthcare, and that wave will create expectations on the healthcare system. So I think the power of people newly insured coming in with expectations of quality of care, of access, of effectiveness, of affordability will be a powerful transforming force in the system. And if there are 4 or 5, if we do our job on eligibility and enrollment, which I'm confident we can, I think we can put those things in place, I think that will put pressure to fundamentally change the way we provide services, and we'll flip it toward actually meeting people's expectations and moving forward. So I think that's the profound change I see, is dramatic increases in coverage and then raising everyone's expectations about what is healthcare and what our expectations are.
Other countries that have healthcare as a matter of right, there's no way to quantify the psychological burden for people in our communities who are a paycheck away from losing coverage, don't have coverage, have a pre-existing condition that is denying them the ability to get coverage. There's a psychological burden that is a health impact that is not very well quantified. So I think the federal reform promises for Californians lifting some of that psychological burden, and yet the challenge of implementation, it will require public education, broader conversation in communities, and reducing some of these many moving parts to be able to communicate with individual families. Where do they fit in? What do they have to do to secure the coverage and sustain the coverage? There's a huge workforce challenge that maybe we'll get into later. But on the one hand, we're talking rather casually about expanding coverage to 4 million Californians, and yet our current primary care provider networks are stretched to the limit and not sufficiently supported to meet current demand, and we're talking about expanding the demand, part of the equation, and it is part of the Affordable Care Act, is more expanded funding for loan repayment for primary care providers who go into underserved communities. I think we should get California designated as an underserved community and not have an apartheid system, but promote not only the training of primary care physicians, but all the related health workforce. And again, a lot of this isn't prospective. There's tremendous work going on in our community colleges at Cabrillo, Hartnell, MPC, CSU, not just nursing programs, which are important, but other health-related programs of radiologists, respiratory therapists, etc. But to get there between now and 2014, I would say is virtually impossible. To commit to expanding it, to me there's a win-win here. We have high unemployment in California, and we're in an economic recession. One way to build out of that is through the expansion of healthcare services and the employment of people in the broad healthcare services, and not just treatment, but on the prevention, wellness, community health side.
This question has to do with the role that all of us in the room have to play in making federal healthcare reform successful. Peter, what do we need to do at the local level to make sure that healthcare reform works for me and for my neighbor?
Start with eligibility and enrollment. As I said at the beginning, health reform is not self-implementing, and the expansions are not guaranteed. So if we don't have our act together in terms of outreach to communities, and we don't have eligibility worked out, I mean, so there's a certain part that the state has to get right in terms of the health benefit exchange of determining someone's eligibility once they try to enroll. But local communities have to create a culture of coverage and believe that there's value in it. And I think the strength that you'll have in Santa Cruz is you're working backwards from what you're trying to achieve, which is a high-quality health system. And so instead of in some communities where Bill's problem is acute that he raised around access to providers and their access shortages, it's a bigger challenge to convince people that health insurance, and particularly Medi-Cal, will lead to better access to care and better health outcomes. I think you all, in the work that you're doing on the 1115 waiver, the low-income health program, are beginning to make strides to fix the system so that it works when people come into the system. So one's eligibility, one is ensure that when people come, they actually see value in the healthcare, and that they, they believe it, because the worst thing would be to get a lot of people enrolled, they don't see the benefit, they turn around and, drop out or don't use the services. The second would be, I think, continuing on your work of value-based healthcare. So no matter where we go in the legislative framework, the regulatory framework, but is actually leading toward the triple aim of better health outcomes, lower cost, and better care experience. And so you all have taken that on. And I think that you believe that it can happen, and it's not managed care of the 1980s and 90s. It's actually a belief that if you align your prevention, you align your education, you set your services up well, you educate the patients, you actually can provide good health care that achieves good health outcomes and is done at a lower cost. So I think the three things: eligibility, enrollment, make sure that your system works for the low-income folks in particular who are coming into the system, and continue your work on value-based health system, because we are going to value-based health care whether we have ACA as it currently is enacted or in some different version.
And just to add to that on the eligibility and access, just to share some specific data, starting in 2014, January 1st, 2014, the largest group who will become eligible based on income, and by us raising the level for Medi-Cal eligibility to those with income under 133% of the federal poverty level. So that raises the ceiling for eligibility for Medi-Cal. And then we're also going to simplify the means for qualifying. Eligibility will be determined and adopted under a new standard. It's called the Modified Adjusted Gross Income, or MAGI, and it's part of the simplification. A person's assets won't be counted against them for eligibility. So if somebody owns a car to get to work, the value of that vehicle is not going to be counted against them for eligibility for the health care. And I'm actually carrying a bill. It's in a 2-year cycle. It's AB 43, And we're going to use this legislation as a vehicle to implement this new category of eligibility and to refine and specify a more streamlined eligibility process. We've also gotten rid of the fingerprinting of recipients of IHSS and providers of IHSS. Finally, perhaps one of the biggest funding transformations, currently California pays about 50% roughly of Medi-Cal that's provided in California. So 50% is federal, 50% is the state. Our budget crisis pushes what we can put up down, and as a consequence, we bring in less federal dollars. As of 2014, the Affordable Care Act, the federal government will pay 100% of Medi-Cal for the eligibility of the category I just described. It will phase down to 90% by 2020. But this is this represents a sea change in our current funding mechanisms. And I think it's critical, again, to link this to the political arena, because it's this funding mechanism that's under attack right now in the federal budget negotiations. So not only is the law being attacked in the courts, in Congress, people are trying to remove elements of these funding equations. And so we need to, the right has coined, with a negative connotation, Obamacare. So in Sacramento, we don't use the term Obamacare. That's been coined by the right to denigrate it and to try to destroy it. So we call it federal health care reform, or the Health Care Reform Affordable Care Act, voted by both houses of Congress, signed by President Obama. And we need to champion the protection of the implementation of this. We all may look at certain holes and defects, but the incremental change that's been implemented already, that I mentioned earlier, in real people's lives, a child not being denied coverage because of a pre-existing condition, you ask that family if they want to change the rules of the game right now. This isn't prospective. This is happening in people's lives in California, in our communities, but there will be a political fight to protect it, to expand it, and to guarantee the funding mechanisms that will allow us to start talking about health care as a right and not as a mandated option for those who can afford it.
There are some federal funds through HRSA in health reform to the access points, and then some capital money for community health centers federally, and I don't think that's enough in terms of, and I think that that's a good conversation. One of the things we're trying to do at the Blue Shield of California is to do an assessment of the field, so every community health center in the state, to assess their readiness to be successful under health reform. And we're looking at their operational efficiency, which is, do you have enough space? Do you have enough capacity to handle the additional patients? What's your payer mix or finances to make sure that clinics aren't overwhelmed with uninsured patients, or that they're not able to kind of succeed in this environment, their quality of care, and then the patient experience. And so based on that, I think then it's a conversation with policymakers at the state and federal level about, look, these are your expectations. We're not, you're not ready to meet them all, and this is what's going to happen. So I think part of what's happened in the past is we haven't systematically collected this data. So we hear is anecdotally, or HRSA collects it. So it's a federal agency that works with community health centers, but it isn't central to the conversation, the health reform conversation. And I actually think that issue that you raised grew 50%, 20%, whatever the number is, at least 10% with the Medi-Cal budget cuts for non-FQHC providers. So you're going to see more financial pressures on non-FQHC, or non-health center providers who have lower and lower reimbursement rates. That potentially can drive folks out of the program or reduce their willingness to see Medi-Cal beneficiaries. It will put more and more pressure on federally qualified health centers to make up the difference. And so I think this is exactly the time, we didn't know what the answer was going to be until last week about that mix. And I think this is a important conversation to push forward. And I think that's part of why it's not self-implementing, and it's part of why you all have to say this is the reality on the ground. You can write the legislation, you can do the regulations, but here's how it plays out. And the dental care, I'm going to punt, my first punt. Blue Shield of California Foundation, we try to focus on community health centers. We will work with our colleagues and raise the issue. One of the things that we found is we try to be incredibly focused. We work in every county with every community health center, and part of that is your dental care, but we can't take, if we started a dental program, then you can diffuse and, work on it. So we're happy to work on an answer with you. This foundation is, yes.
On the question of dental, optometric, what I would call essential benefits to human health and healthcare. And this is part of the ongoing debate as it rolls out. What will be considered essential benefits on an exchange product? Will there be optional coverage for optometric, for dental, etc., and you pay accordingly? The answers to those questions aren't worked out. We've got between now and 2014. What I will say as a matter of health policy, my wife's a family practice physician, and her complaint working in an FQHC clinic was she was practicing what she called body part medicine. They'd have a pay source for a mammogram for a woman, but there'd be no pay source. She wouldn't be eligible for a full physical. And you can't practice good medicine if you're only receiving funding to examine one part of the body. We all know body and mind are an integrated health system, and if you don't have dental health, if you don't have eye health, you're not healthy. So I think you're going to find there's strong support, at least in one caucus in Sacramento, to push for expanded inclusion of dental, optometric. The fight this year around autism is an example of, we passed that bill last year and it was vetoed. We passed that bill this year and now it's the law of the state of California. And so we're not even waiting for 2014, although a component of that bill does defer to evaluation depending on whether the federal government includes autism as an essential benefit for coverage. But we've provided those families now for the next 2 years with guaranteed coverage in the California market. I do want to just mention too, I just want to acknowledge the health insurance industry, who were often on opposite sides of some of the policy debates. In my view over these last 2 years, they've been fully committed to preparing for health care reform, for the Affordable Care Act. And I think a lot of folks in the public don't see that. There are ideologues who oppose the Affordable Care Act, but it hasn't been coming from the health insurance industry who testify in our hearings. We often don't see eye to eye on nuance or maybe essential benefit arguments, but they are realigning their entire coverage plans in anticipation. So I think that's important for people to understand, and that may be something that's also unique to California. I don't have experience what's happening in other states, but that should be recognized. There's a lot of people pushing in the same direction right now. We're in a system now that treats disease and illness and broken bodies, and that's how the economic system is oriented. That's where the money is in healthcare. It's treating disease and illness. And we need to move an economic system that figures out how to incentivize the promotion of health and wellness and prevention and reward people for not going to the doctor, and to figure out how to reward those in our healthcare system for keeping people out of the hospital. And there's some healthcare plans now are incentivizing tobacco reduction, other preventive practices, reducing premiums, trying to build in certain incentives. But one size doesn't fit all, and we have communities that have varying levels of education, varying levels of access. But again, not to put a damper on prospects, I agree 150% that the role of government and health policy should be promoting health and wellness and treating whole and healthy communities. And yet we're in a system where the average child today in California in 1 year will see an average of 1,000 TV commercials promoting fast food or soft drinks. So I have a bill, AB 669. It would put a 1 cent excise tax on sweetened beverages. And it's a 2-year bill now because we received a full court press from the industry. It is a tax. We need 2/3 vote in each house to make it law. But if my bill were passed into law, it wouldn't take soft drinks off the shelves. It would increase the cost at the retail level, assuming the producers pass on that excise tax. 1 cent per fluid ounce would generate in the first year $1.7 billion, and we would have that fund be the California Children's Health Promotion Fund. It wouldn't go to the general fund. It would go to promoting health and wellness with children, and it would go into K through 12 and into community nonprofits and health departments working in collaboration. Would it solve the problem? No. But we do know that sweetened beverages account for the highest increase of caloric intake of young people. So in my bill, I was accused of social engineering, nanny government, social engineering. And I had my Republican colleagues up on their microphones just teeing off on this. This is the perfect example of nanny government. And so then I would raise the question of public health around cigarettes and the increase of taxes on cigarettes and a direct correlation to reduced tobacco consumption. And they say, but tobacco is inherently lethal and a soft drink isn't. And I said, but a soft drink has no nutritional value. There is no nutritional value, and we know the adverse health impacts of overconsumption. So I'm the social engineer. We got a document. It's in a advertising journal. The article's written by the CEO of Coca-Cola, and the headline says, Coca-Cola seeks to double revenues by 2020. So that's the business objective. Then you read his open letter to this advertising journal. How will Coca-Cola, which already has huge revenues internationally, double those revenues by 2020? They've decided to target their advertising to teenagers who change every 6 years. You've got a new group of teenagers. So we have to target teenagers. So that's the who, and the how is through music and the arts. And so they're paying a group called Maroon 5 to go into a recording studio. Listen to this. Social engineering. I'm the social engineer. Is anybody putting a spotlight on what Coca-Cola is doing? They are paying Maroon 5 to go into a recording studio in London, and the only condition is that the song they record has to promote the consumption of Coca-Cola. And then that's going to go out to target the youth market, not just in the United States, but internationally. So when people want to talk about social engineering, we live in a system that is built on the promotion of profit generation without consideration to health impacts or who's going to pay for those health impacts. And that's the fight we face. We have to frame it in those terms. And the only way we succeed in the public health side of treating the population is to find ways to minimize that inordinate and extraordinary influence on young people to make unhealthful choices in food selection.
I'd like to associate myself with those remarks. I have one just addition, more my wonky side, is I think until we start measuring health across the board and kind of come up with a common definition of what we think is healthy, mental health, physical health, spiritual health, we're going to keep everyone inside the medical, people who are trying to do the right thing. So this is the anti-health. I think we have to have a message and work on that. But within the distribution of resources we spend on healthcare and public health, we have to start to think about a generic or a consensus definition of what is health and what are we trying to achieve. And it's a grown-up conversation that we all need to have as Americans and Santa Cruzans and Californians about what we think, because right now what people do is define the health outcome as the hip replacement health outcome is can you play tennis next week, and the heart valve replacement is this, outcome, and everybody meets their own outcome because they get to set their own outcome measures. And so we'll never be able to compare apples to pomegranate trees to, the ocean until we have a standardized measure of what we think health is. And I think that, to me, that's a critical. And the second is, I think, and we're working on this as the foundation, we're investing resources in seeding that conversation. The second piece is rethinking what primary care is. I think it's a somewhat of an answer. Right now, we're trying to catch up for 2014, but unless we fundamentally rethink what healthcare is, and it's home monitoring, it's navigators, it's all sorts of things, and rethinking what primary care is, and we've medicalized primary care to such a degree, that will, I think, also change the conversation. But we have to have the right outcome measure, and then we have to do a lot more about the diversity of who we are and where we come from. Because the other thing everyone screams about in the medical world is risk adjustment and genetics, and people were, preordained to have this. Until we begin to have a much better understanding of the diversity of who we are, we're not going to be able to have an integrated conversation. So I think that, to me, that's the long-term conversation we need to have. And then I think in the short term, you really need to take on the anti-health provisions. And health at all policies, I think, begins to do that. If you actually begin to, every time you see Coke doing this, it's reducing health of our population, it's reducing health of our communities, that makes sense to tax them.
I'm baffled by what's going on with Medicare. I know Bill and Alan, you were both part of the presentation at Simpkins 6 weeks ago about what's going on in Medicare. What are we doing for our old folks? I know it's not sexy, it's not a great topic to have to bring up, but the reality is these are people that have served our country, that have paid their taxes, that have built infrastructures here. And the baby boomers, my mother being that first generation, are right there ready in the aging population. And they are not going to stand for what we're doing right now. And so my question to the state and to the insurance companies is, what are we doing for these people as they're aging? How are we going to care for them?
First, I want to thank Sherry not only for her leadership of the Elder Care Center, but for her advocacy on behalf of adult health daycare statewide. It's one of the tragedies of this budget in this last year, the elimination of adult day health care. We thought there had been an accord with the administration to reduce funding by about half, but to maintain a base level of funding, to maintain infrastructure. And then the governor used his blue pencil to pursue what had been in his earlier budget, the elimination of adult health daycare. So the way it's explained and justified is in-home support service, other forms of community support, continued Medi-Cal, Medicare eligibility, etc. But when we were in the budget hearings and when we asked the governor's department heads if they had calculated the out-year costs of the elimination of adult health daycare, in other words, what will be the attendant costs of more people being institutionalized instead of $90 a day to $1,000 a day in an institution, and there was no answer. They hadn't done that work. And so we hear time and again, penny wise, pound foolish. Again, it underscores the gravity of the crisis. I think the media underreports the gravity of the crisis sometimes. Maybe that's good. It would probably provoke panic. But it puts us on the ropes of trying to protect existing programs' integrity, not being sure of what the transitional impact or health will be of a plan B. And then back to your core question, Sherry, whether it's the federal government or the state government, what is the plan for long-term care for the protection of seniors who in our culture are often put out of sight, out of mind. Other cultures, elders are often cared for in the home, but to a point where even home care is not adequate. And so I don't have an answer to the question other than it needs to be part of the conversation of healthcare reform, healthy communities, and articulating, there's that saying, was it Camus or somebody, that you can measure the level of culture in a society by looking inside the prisons and how they treat the prisoners. I think you can alter that to say by looking at how elders and seniors are cared for and provided for. There's some mechanics in the Affordable Care Act and some of what California's done of dual eligibles and certain transitions of Medicare coverage to dual with Medi-Cal eligibility for dual diagnoses. There's so many moving parts, and the assurance that you get at a budget hearing is not very assuring. And Peter was referring to this earlier. You can have a 9,000-page law, but the implementation is what happens in our communities. And if you starve the resources to the communities, no matter how you describe your approach to getting there from a policy point of view, you can't do it without resources. So unfortunately, our discussion of health policy, the care of elders, the care of disabled, the care of children, needs to articulate a healthy vision for that care and support, and a price tag to achieve it, and an equitable way to raise those revenues to implement it. And that's what's missing right now in our body politic, is the ability to commit to certain outcomes that we would agree would be desirable outcomes, and a commensurate way to raise the resources to pay for those outcomes.
Neither conversation is over. I've talked to people in the last couple of weeks about, I think the state officials recognize this is one of the ones where they don't feel proud of what they've done, and they don't, so they are open to ideas that can make it work. And I think this would be an ideal time to go back to them and say, let's revisit this conversation with some solutions, with other ways to think about it, and let's be creative. And I think at the federal level, the Class Act, I think the way it was written in the Affordable Care Act, I think there's a distinction here. The way it was written in the Affordable Care Act made it inoperable or unable to be implemented. That doesn't mean that this administration doesn't think the Class Act is a good idea, but 75 years worth of viability, a 75-year lifespan with the budget numbers they were seeing and the models didn't quite work. I know for a fact that people are looking at, well, what if we could guarantee 40 years or 50 years of kind of financial sustainability, and are rethinking it to kind of rethink and redo the public policy. So I would say on both cases, in the state we've screwed up, or the state has kind of botched this one. And I was with Toby Douglas last week at Department of Health Services. I think, and Diana Dooley would acknowledge this is not their finest moment, but I think that's a great opportunity to go back in and say, let us be part of the solution. Let us figure out how to make this right. And at the federal level, I think folks like SCAN, Bruce Chernoff, and others here in California will drive that class conversation so that we don't drop it. So I said, neither conversation is over. I think these are intermediate bad outcomes, but this certainly can't end here.
A related area I alluded to earlier, pension reform. Governor Brown's proposal, and it's just that, it's a proposal. It'll get negotiated when we go back in January, proposes raising retirement age to 67 for public workers. Well, 67 with extended lifespans, etc., may be a legitimate objective for some of the workforce. But for blue-collar workers, for people working out on highways with Caltrans or public safety officers, 67 years is a long time to be working in physical manual labor, and for some it would be a death sentence. So we need to measure the public health consequence of raising a retirement age to 67 across the board, one size fits all. And there's other elements to that. But you talk about support for senior community and elder community. How do you build sustainable retirement for people that commit themselves particularly to serving the public, whether as school teachers, public health workers, whatever. And it pains me to see teachers vilified for the crisis of our budget. Most teachers retire in California on less than $3,000 a month in STRS, and they're not eligible for Social Security. So the narrative needs to be told. The real human impacts of some of these proposals need to be described. And health touches every other issue we talk about. When we talk about the environment, when we talk about climate change, working to protect our environmental integrity, the direct consequence of these trends is adverse impacts on human health. So we care about marine mammals, we care about endangered species, but we as humans are also an endangered species if we don't understand the integration between a healthy environment and healthy communities. Immigration issues are federal issues. We have addressed them at the state level with respect to higher education, the DREAM Act. I think we should support a DREAM Act for coverage of children in the state of California, regardless of legal status.